I will speak in English, but prije svega želim da se zahvalim organizacijnom komitetu, posebno profesorki Andonov, koja mi je omogućila da danas budem ovde sa vama. To je za mene zaista velika čast. Imali smo prilike da se upoznamo na Evropskom kongresu dečjih anestezijologa prije mesec dana, tako da mi je jako drago da nastavljamo druženje ovde u Sofiji i nadam se da ćemo se ponovo vidjeti u Srbiji. I have to switch it to English now. Niš is an old city, as Sofia, and is notable as the birthplace of Constantine the Great and two more Roman empires. Constantine the Great introduced Christianity to the modern world. And what is the connection between Niš and Sofia? Romans started to build Via Militaris in the 1st century with Niš and Sofia as two key towns on this long path between Singidunum and Constantinople. Nowadays we are building Corridor 10 and we hope that we are going to get to Sofia and from Sofia to Niš in 1 hour and a half. But last year this path could be called via migrants because thousands and thousands of migrants passed this way. And this is the beginning of the first case. One family of migrants was injured in a traffic accident under completely unknown circumstances. They were found near the highway in between Pirot and Niš. They were rushed to the nearby hospital, then transferred to the neurosurgical clinic in Niš. After the medical examination, 5-year-old child was referred to University Children's Hospital in Belgrade for the further treatment, and that was the moment when they called me to go to follow this child and the mother as an accompanying person to Belgrade. I came to the room and found this situation. Would you believe that this woman here was presented as accompanying person? Who of you would accept to transport this person as accompanying person? Nobody. I started a quarrel. I had a big quarrel with the chief of the department, but they forced me to transport the mother. And this is the beginning of the story. Sorry. I asked, what about the rest of the family? They told me that they will take a taxi. As we all know, a doctor should strongly discourage family not to follow ambulance car. But even more, I found whole family in front of the ambulance car with all their possessions, these bags. I asked what to do now. They told me to call a chief of the director of the hospital. They told me it's a special circumstance, so you should take them all to the ambulance car. What happened? I put this mother on the chair to sit behind without seatbelt. And what happened? Because her neck was stabilized, because it was a fracture, C2, C3 was suspected. Actually, CT scan revealed that there was no fracture. What happened? Mother fainted in front of the University Children's Hospital. Hospital, where she needed to continue a treatment as an outpatient, refused admission because it wasn't a receiving day for that hospital. I had to go to Military Medical Academy to get a specialist opinion that she could be treated as an outpatient. What now? They prescribed medicine. I had to go to the pharmacy and I called the police. They told me that they're too crowded and they don't know what to do with this family. I decided together with the driver to transport the whole family by the ambulance car to the asylum camp, to the refugee camp. I waited for the translator to explain how prescribed medication should be taken and translated the end of the story. Who came was for Arabic, not for Pashto or their language that this family knew. So this is very, very badly organized transport. After that, I realized that I made several mistakes and I broke national law. My only wish was to be a human and not to destroy the family. So I Googled a little bit and found one great research paper, British research paper. Should parents accompany critically ill children during inter-hospital transport? And they listed adverse events that could be happened. One of them was, I listed that I had 5 adverse events. First of all, we were delayed because we were waiting for the slippers for the mother. Second, mother fainted, nurse fainted because of the crowd in the hospital car. It was really bad transport. And I asked myself, could I put a veto on this transport? Yes, I could. Why? Because there was a lack of space, patient required medical attention, patient was too unstable, family didn't speak English language, Serbian language, there was lack of place, and mother, she also required medical attention. And even more, I found one Canadian article that all doctors that transported families, which is not advised, should pass some kind of education, family-centered care education that I didn't have. The second case, also my case. 18-month-old toddler was spending a weekend in a village summer house. During the child birthday party next door, she got a high fever. It happened at 7 p.m. At the same evening, she received corticosteroid at the small local polyclinic and sent home back. It happened at 8 p.m. Several hours later, high-pitched sound when breathing started, accompanied with painful swallowing. Parents took her to the local hospital, 1 after the midnight. Child started to draw. I felt great comfort, were sitting up or leaning forward. We all know maybe this is the case of, we'll see. ENT specialist examined the child, made laryngoscopy outside of the operating theater, mistake, and referred the child to the tertiary ENT clinic in Niš. ENT clinic in my city was informed about the transport and prepared for the arrival. Local hospital organized the transport, and unfortunately, anesthesiologist, this poor anesthesiologist, was accompanying the child. Ambulance car broke after 100 to 200 meters. The child was transferred to another ambulance car. After an hour of transport, breathing deteriorated. Anesthesiologist tried to assist breathing. At the entrance of my clinical center, the driver, could you believe, the driver advised that it would be better to drive to the emergency department of the pediatric clinic. The access is easier. This clinic is 300 meters away from the clinic where they were referred. Because of the shift, because it was 8 in the morning and all pediatricians were in a meeting room, the youngest resident was in the emergency department, and he called the ENT specialist for consultation. And this ENT specialist waited for the difficult case to come at his department. At 5 minutes after 8, resuscitation started, intubation was impossible. 20 minutes after 8, ENT specialist performed tracheostomy. But unfortunately, they called me after. I couldn't establish the airway, and post-obstructive pulmonary edema developed, and child died 10 minutes after 9. Disaster case. So, what we could conclude: don't be forced into scoop and run scenario. There could be some exceptions, but in this case, not. In Serbia, it was the case of Haemophilus influenza type B. Because of this case, Hib vaccination was introduced into routine childhood immunization in 2006. If there is any doubt about the need to ventilate or intubate the patient or secure the airway, it is preferable to intubate before departure. Why? because ability or inability to clinically assess the patient during transport impact so-called prophylaxis. It's very difficult to see if the patient is blue, pink, white, gray. Stethoscope is unavailable. It's very difficult to monitor the patient non-invasively. Third case, we had to transport the child to Belgrade 2 months ago. But what happened? One truck loaded by paper caught fire, and the ambulance car passed through the blaze and continued the way to Belgrade. But after that, the stop on the highway lasted for more than 3 hours. So I tried to investigate how frequent is this kind of occasion. And I found one study from Great Ormond Hospital, London, that it could be happening in 1 to 959 transports. But I think it's more frequent. And what if we had to wait for 3 or 4 hours on the highway with unstable patient? Fortunately, the patient was quite stable, but what if? Critical aspect of any transfer is what you don't have, you can't use. So all necessary supplies and equipments should be prepared and must be checked prior to department, and it's always important to have a plan B, actually to anticipate possible problems. So transportation feng shui says that always patients should be placed in the car and equipment should be packed in the car and according to the anticipation of what can go wrong, because access is vital. We have simulation in the ER, we have simulation in the emergency department, we don't have simulation in the ambulance car, and you can't in my city. How to decide how to transport the patient? It depends on the distance, traffic density, and condition of the patients. Very important is transport physiology, what it means. Acceleration and deceleration change cardiac output. How? During the acceleration, cardiac output is declined, so hypovolemia is really dangerous. Also, any deceleration increased cardiac output and increased cerebral blood pressure, intracranial pressure. It's very dangerous also. So normal road speed with minimum changes is necessary during the road transport. We usually have prepared patients for a fixed transport. Fixed wing aircraft usually fly nose up, and patient should be placed feet first or transferred. It's more safer. And we sometimes perform helicopter transport. Ideally, the patient should be positioned across the direction of the travel because of this strong acceleration and deceleration turbulences. And I would like to recommend for the end one beautiful, beautiful article that divided all complications regarding transport into 7 groups. First group is consisted of equipment problems, equipment failure, disconnections, vascular access problem. I want to stress that in pediatric scenario, pediatrics, after the vascular access is assessed, syringe pumps should be used, not gravity pump, because of the motion. It's very difficult to restrain a neonate in the incubator, and sometimes during the accidents, during the motion, during the driving, it could be very, very difficult to keep a baby in a neutral position in the incubator. This is the case from Northern Ireland 2 months ago, when oxygen exploded and the patient died and 2 paramedics were severely injured. Patient care problems. These all problems listed could be connected to the case number 2. Patient condition was more severe than expected. Inappropriate or inadequate preparation at the referring site, hospital not prepared to receive patient, deterioration of patient condition. inadequate patient preparation for retrieval, airway obstruction. You usually have a problem when loading neonatal incubator and all this stuff connected to the neonatal incubator. It's very difficult to load it, everything in the ambulance car. Also, bad weather could be a problem. This is the picture when I had to transport neonate, severely injured neonate for St. Valentine's Day during the snowstorm. Also, I had to organize one plane transport to Basel, of course, during the New Year's Eve, and it was impossible for plane to land in Constantine the Great, my airport, and they landed at Nikola Tesla Airport, and because it was New Year's Eve, I couldn't organize ambulance transport to Belgrade. It was also very, very difficult transport. And I want to say almost at the end, for our doctors, we should escape from our medical book, Ivory Tower. It means we don't have to be arrogant to our colleagues, whether we are transporting the child, whether we are accepting the child. We should praise their efforts to save the patient. Usually, in my department, the youngest doctor doing the transport, which could be very tricky for them and tricky for all of us, because they are not prepared for this, sometimes for very, very difficult cases. And all human-based factors could be divided into three groups. Rule-based mistakes, when policies and protocols are not followed. Skill-based mistakes, because we are in big stress and distracted by the situation. And knowledge-based mistakes, I would like to stress also wrong and inadequate knowledge. And the take-home messages. It's never acceptable to transfer patient if the patient is not at least so stable. Speed kills even in an ambulance, and we should communicate better. And for the last slide, I would like to say, these children, they're playing at home before they go out. So our experience from the emergency department, from the operating theater, from intensive care, we should use it as advice how to react and how to behave during the transport. Thank you.